Good morning, good afternoon, or good evening. Depends on where you are. Thank you for joining us today. I'm Satoshi Kusuda, a neonatologist working in Tokyo, Japan. Today we have a distinguished guest speaker from Iowa University, United States. I'm so honored and privileged to have Professor Edward Bell for the lecture today. As you know, he's a leading neonatologist in the world with successful care of many preterm infants at the limit of viability. I believe he started registry of tiny infants with birth weight less than 400 grams almost 20 years ago. When it started, only a limited number of infants were registered. However, as perinatal care progresses, more tiny infants are now registered. And the registry has become the largest and most valuable data set at present. Without further ado, let's hear the important lecture. Ed, please.
Thank you very much, Professor Kusada. Before I begin my presentation, there is one thing that Professor Julie Oy asked me to share with you, and I meant to thank her, of course, and the committee for inviting me. She asked me to share with you this website, which is called the Tiny Baby Collaborative, which is a creation of Dr. Matthew Rashavi at the University of Texas in Houston. This is a very new collaborative of 7 centers until now, all of which have survival rates above 50% for babies born at 22 weeks. And the purpose of this group is to share experiences and try to learn what we all do in common, and to create a common database from which we might learn more about these babies. Here you can see Dr. Rashavi, Katrin Mailer from Cologne, and some of the other members of this collaborative. Here's Professor Kusada and myself. This is a very new organization, and we would encourage you, if you are interested in learning more about this or potentially joining, to contact Dr. Rashavi, and I can provide you with this contact information. It's probably on the website. These other pages are still under construction. There is one publication, actually several publications from the group already. I have no conflicts to declare. I do want to acknowledge that some of the slides I'm going to show you were created and provided or created in partnership with Matt Rashavi. Here you can see the University of Iowa Children's Hospital, where I work, and just across the street you can see the university's football stadium. And this is important to know about because there is a phenomenon called the Iowa Wave, and I encourage you to Google this and look for the 6-minute video that you'll find there by the ESPN Sports Network. But at the end of the first quarter of every university football contest, all of the 70,000 spectators in the stadium turn and wave to the children in the hospital. And this is what it looks like from the rooms in the hospital. It's quite an inspiring thing to watch or participate in. And the football players and the coaches and the officials turn and wave to the children. Here's what it looks like at night with everyone's phones turned on. In 1973, my first year of residency, we didn't intubate most 28-week infants because to do so was considered futile. They would all die anyway. In 2022, we don't intubate most 28-week infants because we don't need to in most cases. So we've come a long way during the course of my career. How did we get to here from there? I think the most important specific factors that I can identify are the 3 A's: artificial surfactant, antenatal glucocorticoids, and active or affirmative care. The gestational age limit of viability has moved over time. In the 1970s, when I started my career, it was around 27 weeks, and every 10 years it's moved about 1 week earlier. And now the limit of viability in most developed countries is around 22 weeks. And how do we know when it's time to start treating younger babies? I've told some of my trainees that the only way to know if the wall moves is to occasionally push on it and see if it moves. So I'm going to take you on a little bit of a tour through this changing landscape. What's happening in the 21st century or in the year 2021 and 2022 with 22-week infants? What do we know about recent trends in active treatment rates and outcomes for these infants? Recent publications have shown continued variation in the treatment rate and the outcome by hospital and country of birth. But rates of active treatment and survival are increasing. This figure is taken from Matt Rashavi's 2015 paper in the New England Journal of Medicine. Each one of these small squares is one of the hospitals in the NICHD Neonatal Research Network. And this vertical axis is the proportion of infants at each gestational age receiving active treatment. And you can see at 26 weeks, almost all hospitals provided active treatment for nearly all babies. At 24 weeks, even almost all hospitals were resuscitating almost all babies. Before 22 weeks, there were almost no infants being actively treated. But at 22 and 23 weeks, you can see there was a wide range of variation. At 22 weeks, for example, there were 4 hospitals where no infants were actively treated, and there were 6 hospitals where all 22-week infants were actively treated, although the numbers of infants were small, as you can see from the large error bars. So the majority of infants survive at most NICUs at 24 weeks in the United States. There are isolated case reports of survival at 21 weeks and no reports of survival at 20 weeks. In the US in 2018, there were over 4,000 live births at 22 and 23 weeks. So this is about 1 in 1,000 live births. And this is similar to the incidence of fetal alcohol syndrome and Down syndrome. But these 4,000 babies accounted for 14% or 1 in 7 infant deaths. Here you can see the mortality rate by gestational age in Japan for the years 2003 to 2015. And if you look just at 22 weeks, you can see the mortality rate back in 2003 was about 75%, and it's come down to around 35% in 2015, and it's continued to come down in the years since then. Shown here is the inverse or survival rates for infants in Sweden by gestational age. And for 22 weeks, you can see the survival rate back in the 1980s was just over 50%. And now, I'm sorry, this is 22 weeks. It was around 25% in 2004 to 2007, and now it's up to about 55% in 2015 and 2016. Here you see data from the United States from the Vermont-Oxford network, which represents about 85% of extremely low birth weight babies born in the US. And for a number of years, there was no change. This is the active treatment rate and the survival rate for 22-week babies. But in 2015, these numbers both started to increase. And the active treatment rate, which was 25 to 30%, has swung upward and is now above 50%. And the survival rate, which was 5 to 8%, is now increased to 17% in 2019. In 2019, in the United States, the majority of 22-week infants were actively treated. And the survival of all infants was 17%. But if you look at just those actively treated, it was 29%. We've now begun to accumulate evidence for the efficacy of antenatal corticosteroids for babies less than 24 weeks. This is from a meta-analysis by Park et al. Published in 2016. And also includes data from the Errett paper published in 2018. And the meta-analysis itself is from Park. For all babies under 24 weeks, you can see there was a significant benefit, a survival benefit for antenatal corticosteroids. If you look just at 22 weeks, this didn't quite reach significance, but for 23 weeks, it clearly did. And this was confirmed by the Errett study, which provided another 7,000 infants. So we have data now on nearly 11,000 infants showing benefit of antenatal corticosteroids before 24 weeks. These are not randomized clinical trial data, but I don't think we're ever going to get RCT data for babies at these early gestations. Just last September, based on these and other studies, the American College of Obstetricians and Gynecologists issued a practice advisory that antenatal corticosteroids may be considered at 22 and 0 to 22 and 6/7 weeks if neonatal resuscitation is planned and after appropriate counseling. The Swedish guidelines since 2016 have recommended that steroids be considered at starting at 22 weeks and 0 days. And the British Association of Perinatal Medicine guidelines also recommend resuscitation be considered for babies starting at 22 weeks. They don't specifically address the question of steroids. Here are some recent survival rates at 22 weeks published since 2018. In 2018, the Errett paper reported for the Vermont-Oxford network survival of 9% of all live births and 29% of admissions. The Japanese neonatal network reported survival of 46% of live births and 51% of admissions. The Swedish National Quality Register reported 30% survival of live births and 58% of admissions. And for these 4 individual hospitals, we see even higher survival rates, with survival rates over 50% of live births for selected hospitals. And I point out this very recent paper from Nagano Children's Hospital, reporting 81% survival at 22 weeks for live births. The numbers are somewhat smaller for these individual hospitals, but the results are rather impressive. What's going on in other European countries? We don't have very recent data, but what we found in a survey published in 2014 was that throughout Europe, there was little consensus regarding how active intervention after birth at 22 to 25 weeks is managed. And country was the biggest contributor towards whether or not active care is undertaken at these early gestations. And here you can see a brief summary. In some countries, there was routinely no resuscitation at 22 and 23 weeks. And only in Turkey was resuscitation reported to be standard throughout the country. So survival rates are improving at 22 weeks. Rates over 50% for actively treated 22-week infants are now being seen in several national cohorts and for all live births in selected centers. Active treatment rate at 22 weeks in Vermont, Oxford network US hospitals have doubled over the past 5 years to over 50%. And survival rates at 22 weeks in Vermont Oxford network have tripled. But survival is not enough. We want to have babies with good quality survival. So what do we know about how these survivors are doing? To be honest, we have relatively small numbers so far because we don't have a lot of these babies that have survived to old enough ages to do very comprehensive evaluations. From the Rashavi 2015 paper, we had only 18 babies examined at 2 years. 39% of them had no or only mild neurodevelopmental impairment. 28% had moderate impairment and 33% had severe impairment. The Watkins paper from Iowa had a similar small cohort. 55% had no or mild impairment, 27% had moderate impairment, and 18% had severe impairment. The Japanese have reported 3-year outcomes for a cohort of 77, and 58% of those had no neurodevelopmental impairment. There were 13% with cerebral palsy, 14% with visual impairment, but only 1 was blind, none with hearing impairment. These are a couple of our 22-week survivors. We're having a handful of 21-week survivors being reported now. This is Curtis Means, who was born at the University of Alabama and is the Guinness World Record earliest reported survivor. He was born at 21 weeks and 1 day. This is a baby from Iowa who was born at 21 and 3, who is doing well at home at 9 months, off oxygen, showing good catch-up growth. He's on no oral medications except vitamins. And there have been published reports, 3 or 4 in the literature. And the Swedish National Quality Registry has been tracking 21-week survivors for some years. And they have about 1 survivor a year. So the limit of viability by gestational age is around 22 weeks in developed countries. But remember, gestational age is not the same as maturity. And we simplify things quite a bit when we talk about the limit of viability strictly in terms of gestational age, weeks and days. We know that other things influence the baby's chance of survival, such as the sex of the baby, the birth weight, if it's a singleton or a multiple, and whether the mother received antenatal steroids. And the National Institute of Child Health and Human Development in the US has had an online calculator for some years. And this was recently updated based on this 2020 paper by Matt Rashavi. And this is based on more recent outcome data from the network. And here's what the tool looks like if you go to this web page. Actually, the exact link is here, but if you want to find it, just Google extremely preterm birth outcomes tool, and you can enter the gestational age, the estimated birth weight, if it's a baby who's not born yet, the sex, this singleton or multiple, and whether the mother received antenatal steroids. And it'll tell you the baby's chance of survival among only actively treated babies, or all babies, including those who are not actively treated, which is, frankly, a rather useless number in my opinion, but we have it on there. And also it'll tell you the risk of these outcomes as well. Here's an example. If you have a girl born at 23 weeks with a birth weight of 650, who's a singleton, whose mother received antenatal steroids, her survival chance is 60%. Whereas a boy who's 2 weeks further along, but whose birth weight's only 550, who's a twin, whose mom did not get antenatal steroids, his chance of survival is lower, only 38%. So at 22 weeks, more than half of actively treated infants survive in selected centers and in several national cohorts. At 2 to 3 years, about half of 22-week survivors have no or only minor neurodevelopmental impairment in several cohorts. But gestational age is not the same as maturity. The new outcome tool may help to predict risks for an individual infant. And if you're a member of the Vermont Oxford Network, there's if you go to the Nightingale website, you can actually calculate the baby's chances based on your own center's outcomes, which is quite handy. And standardized approaches agreed on by providers improve outcomes and patient experience. So this addresses the limit of viability based on gestational age. Now, if we look in terms of birth weight, how small is too small to survive? This is a baby born in Singapore, weighing only 212 grams, who has survived and been discharged home. And this is the smallest baby that I'm aware of that's survived to discharge. This is the Tiniest Babies Registry, which Dr. Oy asked me to talk about. This is a website, a web-based registry that I started 22 years ago. It's for babies who survived with birth weights below 400 grams. And the web page first went up in January 2000 with 15 patients. And as of a month ago, there were 291. I think we have just one more since then. The birth weights range from 212 grams to 399 grams. There are 45 babies below 300 grams. The gestational ages range from 21 to 34 weeks. And of course, all except 10 were small for gestational age. And 68% of the babies are females because of the female survival advantage at extreme preterm gestations. Here you can see the gestational age distribution of the babies in the registry. The most common gestational ages are 24, 25, and 26 weeks. This 34-week baby was born in the 1930s, and so I don't know how accurate the gestational age is or even the weight. These are the years of birth. Oddly enough, there were 3 babies born in consecutive years in the 1930s that I was able to locate. But then there were none for 50 years. And now the numbers have been increasing over the years. Here you can see the countries of birth. The United States, Germany, and Japan are the 3 big contributors. I should calculate this based on entries per 1,000 or million population. That would be an interesting way to look at this. And of course, these are almost all from developed countries, high resource countries. This was the first under 400 gram baby that we had at Iowa, and she was the one that stimulated my interest in this population. When she was born, her parents said, "Are there other babies this small that have survived?" And she was a couple of weeks old at this point. And I said, "I know about one other one that I read about in a magazine, but I'll look and see what I can find." And so this was the beginning of my collection. And this was the other one I knew about. She was born 5 years earlier and had been reported in People magazine. And she was the smallest survivor for 15 years until 2004, and now she's number 25. She's been reported in the New England Journal of Medicine. She was born in Chicago. And this is another Iowa baby. It goes to show you that they're not all talented musicians and college graduates, university graduates like the previous one. But he's a pretty good boy. This is another Iowa patient, and there she was at 4 years. This is another Iowa patient. And this is an Iowa patient at age 17. So how do these tiny under 400 gram babies do long-term? We have limited long-term outcome data in the registry, but what we know from the registry is that most patients, they remain low weight for age, and many are shorter in height than average. Some experience delayed development and more serious health concerns. But we do have a more informative data from the NICHD Neonatal Research Network Extremely Preterm Infant Registry. And we analyzed the babies under 400 grams from this large database and published them in 2019. Even though it's a large database with some 30,000 babies, the number of survivors less than 400 grams was rather small, and those with 2-year assessments was even smaller. We only had 19 infants that we could evaluate that had complete 2-year assessments. 12 of them had weight, length, and/or head circumference Z-score of -2 or worse for age. 12 had required rehospitalization. 9 had feeding problems. 7 had pulmonary problems. 8 required some form of medical equipment. In terms of neurological outcomes, 8 had impaired vision, but none was blind. 1 had hearing impairment. None had autism spectrum disorder. 11 had abnormal neurological exams, including 3 with cerebral palsy, but only 1 severe. And their median Bailey scores were in the 70s. Unfortunately, these were the definitions for neurodevelopmental impairment. Among the 19 infants, 9 had severe neurodevelopmental impairment, and 1 of these was profound. And that was not surprising, but it was disappointing. And so what we have to remember with this population is that these infants had growth failure in utero at a really critical time during brain growth and development, which increases their risk of adverse neurological outcomes. And in most, the poor growth continued throughout infancy, which is also a critical period for brain growth and development. So unlike the normally grown 22-week infants who have a 50% or better likelihood of a fairly good outcome, that's not the case for these severely growth restricted babies. So in summary, the limit of viability for gestational age in developed countries is 22 weeks. More than half of actively treated infants survive at selected centers in several national cohorts. And a third to a half of these infants have no or only minor impairment in several cohorts, although the numbers are small. And in terms of birth weight, we've seen there are survivors under 300 grams, but in 26 of 101 actively treated infants in the NICHD network survived to discharge. The number assessed at 2 years is small, and the results are not encouraging, and nearly half had severe neurodevelopmental impairment. So here's the glass. Is it half empty or half full? That depends on your perspective. Thank you, and I welcome your questions and discussion.
Thank you, Ed, for excellent lecture. I believe everyone was so impressed by your lecture. Yes, we have a time for taking questions from audience. So if you have a question, please enter the chat panel or raise your hand and turn on your mic and video to ask directly. Today we have almost 200 audience, so quite a big number of lecture today. First question is from Gayatri Jep.
Skincare.
Skincare.
Yes.
Yeah, skincare. Can you comment?
Yeah, that's it's a really important question. I think good nutritional care. We're very careful with what we put on the skin. Within the Tiny Baby Collaborative, we found that we don't all use the same approach. If you use alcohol to cleanse the skin for placing lines, be sure you wash it off immediately afterwards with sterile water. Some people in our collaborative don't use EKG electrodes. They just use pulse oximeters to monitor the heart rate. We use EKG electrodes. We use special materials, special types of electrodes we use a product called Mepitel underneath some of the devices that are attached. It's really important. Some people think that humidification helps. It may help in the first days, but after that, humidification delays the maturation of the skin, and so there's a lot to be discussed and debated about that. Our collaborative has published a paper that addresses this that I can refer you to if you send me an email.
Thank you, Ed. I don't think we have already established way to how to actually care the skin of this tiny infant, but each facility is trying to do their own way. So Martin from Australia, he raised hands, so you can turn on your mic and video and ask directly.
Thank you. Thanks very much, Dr. Bell, for a fascinating talk. Martin Kluko from Sydney in Australia. Just wanted to ask about how your unit copes with the procedural challenges of a very tiny baby. And is there a dedicated team of nurses, medicals and RT that are involved specifically with the care, or are they under the care of the general unit and everybody is responsible for the procedural work? Because that's been a big challenge for us whenever we had a very small baby, is just getting body access and airway access.
Hi, Martin. We do have a special area of the unit that is devoted to care of the tiny babies, and only selected attending neonatologists and nurses work there. I think that's really important to have a dedicated core team that takes care of these babies. In terms of procedures, our approach in ventilation, we use first intention high frequency jet ventilation with 2.0 millimeter endotracheal tubes. Most of these babies get umbilical vein and artery catheters early on, and keep them for a while to try to avoid having to do venipunctures and capillary punctures. We try to minimize handling. Our own approach is to use radiant warmers with protective barriers of thin plastic wrap across the sidewalls to prevent convective heat loss. But I know other units in our collaborative, most of them use incubators and added humidity. So there's more than one way to skin a cat or a catfish. But I think the most important element of success is the culture and the belief that these babies can and should survive and have good outcomes, and that has to be subscribed to by everyone, from the obstetrician to the nutritionist to the everyone who has any contact at all with these babies.
Thank you.
Thank you. So next question is, any advice about fluid management in these infants?
It has to be done very carefully, very precisely. These babies can have very large insensible losses in the first days, and you've got to be prepared to replace those. Your margin for error is quite small, so we may weigh the babies several times a day. We keep a close watch on their sodiums. We start amino acids right away, which minimizes catabolism and minimizes the risk of hyperkalemia, which we used to see in the early days before we knew what we were doing. We start colostrum as soon as it's available, unless there's a specific GI contraindication.
Thank you. Maybe we need standardized procedures for tiny infants, but not yet. It's not possible yet.
You know, I'm not saying that ours is the only way to do it, but you know, Satoshi and others in our collaborative have slightly different approaches.
Yes, so someday we need international kind of collaboration.
Yeah, I see a question in the chat box about cardiovascular complications.
Long term outcome.
Yeah, we don't have enough of these babies that are old enough to see late childhood and adult complications, but we are concerned about renal and cardiac outcomes for these babies, and we're going to be monitoring them. In the short term, we have a very active neonatal hemodynamics group that helps us monitor their PDAs and cardiovascular function, and helps us decide how to manage the PDAs.
Thank you. Yes, we need long-term follow-up, but not actually possible to get the data because number is small, and also long-term follow-up is also burden for infants themselves. So we have to continue to some effort. Next question is being born female. Apart from being female, what's the predictor of good outcome?
The hospital of birth.
Okay, so we have to select the hospital first.
There's a website. There's a patient advocacy group called 22 Matters that maintains a website that shows all the hospitals around the world that have successfully treated 22-week babies.
Yeah, that's very important factor. Next question is about the birth rate and gestational age. So rather than gestational age, birth rate or SGA, how do counseling the parents?
I think we tell the parents what our own outcomes are, and we try to judge how much detailed information this particular couple needs. Some people like to have a lot of statistics and some don't need that, but and then we let them decide, and when they hear our outcomes, most parents at 22 weeks request that their children be resuscitated.
Okay, so next question, I think this was from Martin. Then how about blood taking protocols, supporting and duration of umbilical cord line?
May I ask that, Dr. Satoshi? Sorry to disturb. Thank you, Dr.
Yeah, that's okay. Yeah, that's okay.
Thank you. I'll pose the question. My name is Jan Klimek from Westmead Hospital in Sydney. Thank you, Dr. Bell, for a lovely presentation and inspiring for all of us. And I think the key message that you gave to us, the correct key message is the culture and belief, because without that, this would not work out at all. So my question is really some practical issues. So we know Japan presented to us a few years ago on their survival rates of 22 weekers, and the central part of that was consultant presence, a persistent consultant presence in the unit for these babies. So my first question is, how much involvement is there directly from senior staff and persistent presence for the senior staff? And the second questions are really practical things like, how long do you keep the UAC? And you said you keep it in a bit longer. We've seen thrombosis of the aortas keeping UACs in too long. Do you ever see that as a complication if you keep them more than the usual 5 days? And the last question is things like erythropoietin and minimizing blood taking on these very small babies. Sorry to give 3 questions in a row.
Our faculty neonatologists are quite closely involved in the care of all of our critically ill patients, but particularly these tiny babies. They're not physically present in the unit 24 hours a day, but they're we always have at least a fellow, and the fellows are freely consulting with the faculty, but no important decisions are made without faculty input. We have a lab directly in the unit that does everything on micro quantities of blood and gives us immediate results, which I think is really important for our good outcomes. It's not just a handheld bedside instrument, it's a full lab with the normal pathology instrumentation. And that helps us to avoid hyper and hypocarbia and acidosis. We can make ventilator adjustments quickly. And the volumes of blood that are required are quite small, but we don't hesitate to monitor things closely and transfuse babies if we need to. We keep our lines in sometimes for several weeks, and we heparinize the fluids. We're careful with the amount of heparin we give so that we don't heparinize the babies. We will take and try to get the UVCs out by 10 days or so, and go with PICC lines unless we need them for central venous monitoring, or unless we need a multi-lumen catheter for some reason. But in these tiny babies, that's not usually the case.
Thanks, Dr. Bell. Would you ever use transcutaneous monitors to try and decrease blood taking?
Just pulse oximeters. I think the skin on these babies won't withstand transcutaneous monitors.
So for example, then for blood gases, sorry, we've got interference. Blood gases, how often a day, 24 hours, would you say do blood gases on these babies, just as an example?
We are interrupted. Please repeat your question, John.
Sorry,
Bell, yeah, okay, yeah.
My question was, how many times in 24 hours would you do blood gases, for an example, just to give us an example?
It might be every 2 hours. Might be every 2 hours in the first day. But we'll have babies who are unstable who will get them hourly. But once the baby's stable, we'll do them maybe twice a day, once a day, or eventually not once or twice a week, just to check the PCO2. But we're talking
so that's significant blood taking in the first 24, 48 hours, so hourly or 2 hourly. That's quite significant even for us here.
Yeah, we're talking 50 microliters or something like that. And it does add up, and these babies all get transfused.
Thank you.
Thank you. So we have still many questions on the line. So next question is, what's the balance between minimum handling and regular weaning, and also echocardiography?
Yeah, we we do what we need to take care of them. We don't try to compromise their care by keeping hands off. But we do try to cluster cares wherever possible so that we're not constantly handling them. Someone asked about probiotics.
Yeah, the next question is, yeah, probiotics.
Yeah, we give probiotics up until the babies no longer have NG tubes. We don't start them until they're getting close to full enteral volume.
Okay, so next question is about fluid management. So how to considering insensible water loss and how to manage the fluid balance, and what's the incidence of hypernatremia?
Hypernatremia is very rare. Hyponatremia is very rare. We monitor the sodium closely. You know, they have large insensible losses, and we replace insensible losses.
Okay, so next question is protocol we can access from outside. We can use different hospitals.
Yeah, we don't have protocols, but we've published several papers together. If you with Satoshi and others, the group in Uppsala. So if you look on PubMed, you can find those, and I'll send them to anybody I'll send them to Julie and one other person that asked in the chat box. But Johan Agren was the first author of one of the papers on fluids in skincare that you might find useful.
So Julie can disseminate that publication.
I think we need to mute a lot of people. Thank you. Yeah, that's great. We really need practical guides. As you can see from the questions here, there are things that we are learning. And I was wondering whether, can I ask a question, Dr. Kutsuda?
Yeah, sure.
Thank you. So, Dr. Bell, do your parents come in expecting active management from 21 to 22 weeks now?
21 weeks, we don't offer active management. The few cases where we've given it, it's because the parents have brought it up and made a compelling case. 22 weeks, we bring it up and we have a conversation and ask them if they want active care, and most people do. 23 weeks, we presume they want active care, but they can opt out, and almost no one does.
Okay, so that's a very different scenario to Australia. And if we have any Australians on deck, it would be great to hear their comments on this. We in New South Wales, currently most of us will not offer active care to 22 weeks and above, increasingly more at 23 weeks. In Western Australia, I think it's been standard of care for 22 weeks for many years. And I think Shripada, if you would like to comment on that from WA, unmute yourself if you're still there.
Yeah, Julie,
thank you.
Maybe I will ask Gayatri, because she works at King Edward, which is the main center for perinatal care for these babies. Is Gayatri there online? Or Deepika?
She was.
Yeah, hi, Julie.
Hello.
Hi. Am I audible?
You are very audible.
Oh, excellent. Look, I mean, with us also, we do offer active care from 23+0. But we recently reviewed and presented actually this data, because since Victoria has gone to include, I think, resuscitation to be considered to be offered from 22 weeks. We recently reviewed our own data, and we have over the last sort of 21 years, 48% survival in babies born between 22 to 22 plus 6. And I mean, most of them, again, were appropriately grown for gestation babies. And I would imagine at least 40% of them had a complete course of antenatal steroids after appropriate discussion with the parents. But I mean, at the moment, we do have 22 plus 6 weeker twins in the nursery. One of them unfortunately passed away with neck last week. But the survivor has a grade 4 IVH on one side. So, I mean, we do see them occasionally, but we have not been offering like active care in between 22 and 22 plus 6. But it's really, the difficulty is when, you know, when they are 22 plus 6 today, and in like less than 24 hours, they are 23 plus 0. So that is sort of, again, discussion which we have with the parents and the family, and then take it from there.
Okay, so Australia is a very big country, so you have different approach to the preterm infant, I believe.
Yeah, I don't know that every hospital should be treating 22-week babies. It takes a special commitment, and you've got to have the full support of everyone. And it takes some time to develop the culture and the skill to do it successfully.
Okay, so maybe back to the questions in chat box. Question about HF, high frequency jet ventilation. Do you use it for first choice?
Yep. It's a very, you know, these babies' lungs are like wet tissue paper, and they're very, very easily injured by the full expansion that occurs with conventional ventilation. And we very much like the jet ventilator for these babies. And I think it's, you know, for us, I think it's been one of the keys to our success. Anyone who wants to read about how we use the jet for these babies, I refer you to the Iowa Neonatology Handbook, which is online. And there's a very, very good section on our use of the jet, written by Professor Jonathan Klein, who's our medical director. We don't have much in that handbook otherwise about specific care of the tiny baby, but that section is very good. It's a handbook that was derived from our resident handbook and has been translated into Russian and Romanian, and there are pirate editions in many other languages, but the authorized editions are just in those 3 languages.
Okay, so we can visit the website and download the.
Just Google Iowa Neonatology Handbook. Yeah.
Oh, okay. So please try to.
Yes, I've put that on the chat pane.
Okay, thank you, Julie.
Oh, Jan says I'm awesome. Really? Okay, Jan, a lot of presents coming your way. I'll come out to Westmead. Thank you.
The gauge for the IV cannulas, it's the smallest ones we can get. I don't know the number, but sometimes 24s, but I think there's some smaller ones that they use sometimes as well.
Okay, so I think Dr. Nishida would like to make comment,
yes,
or would like to ask questions.
Thank you, Dr. Kishida. Well, I want to comment to Dr. Bell. I thank you for your long time effort for the tiny baby. Because of your registry, some baby had chance to be saved. Well, you know, our policy is fail safe. Unless you try, you're not gonna save the baby, right? So you gave a chance, at least idea. Thank you very much, Dr. Bell.
Thank you, Professor Nishida.
I have to apologize that we cannot go through all questions posted on the chat panel due to the time of limitation. I believe Ed can answer all questions by email later.
Yes, I'm happy to answer them all by email.
Okay, thank you. So thank you again, Ed. We are looking forward to further discussion in near future, possibly in person after the COVID pandemic is over. So thank you everyone for attending this very important talk. And until then, we can meet in person. Everyone, please stay safe and healthy. Thank you, everything.
Thank you very much, Dr. Bell, Dr. Kusuda.
Thank you. Thank you.
All the best. Thank you.
Thank you.
Bye-bye.